in Houston, and appreciate your being here today. My name is Angelique Kapoor Davis. I'm a volunteer with ThyCa. I'm a 20-year thyroid cancer patient, RAI resistant, support group facilitator, and board member. And I really appreciate seeing so many familiar faces too or names listed here in the online group. Nice to see you all. This is session 331, Drugs in Development for RAI-refractory differentiated thyroid cancer with Dr. Mabel Ryder. Dr. Mabel Ryder is an endocrinologist at the Mayo Clinic in Rochester, Minnesota. She earned her medical degree at the University of Texas and completed her fellowship and residency at the University of Cincinnati College of Medicine. Dr. Ryder specializes in head and neck cancer and nuclear medicine therapy. She's contributed to many publications on thyroid cancer, and Dr. Ryder is a 2007 ThyCa research grant recipient. So welcome and thank you so much, Dr. Ryder, for joining us today.
Thank you, Anjali, and thank you for our virtual producers helping, and thank you for the audience participation and engagement. Gary asked me to talk about drugs in development for radioiodine refractory thyroid cancer, new molecular targets, but I probably should rewrite this new and old targets, as you'll see in just a moment as I go forward. And hopefully we'll have enough time for questions at the end. Okay, so the objectives are to identify novel approaches for advanced thyroid cancer, and I'm going to focus on three areas. One, salvage chemotherapy with pemetrexed carboplatin. This is really an old regimen that I think really has a place in advanced thyroid cancer. Then the TSH receptor CAR-T trial that we're developing at Mayo, and we hope to open in a year in the future, but it is on the horizon. And then I'll highlight 2 select clinical trials for advanced disease with new agents. So if you were with me in my last session, or if you heard me speak before, I kind of break down thyroid cancer in my mind when I'm talking and seeing patients and when I'm thinking about the disease into this WHO 2022 classification, which I think is really important. It really breaks down thyroid cancer into different types of classical papillary thyroid cancer driven by BRAF mutations, to RAS-driven thyroid cancers that are primarily follicular patterned lesions with follicular variant and follicular thyroid cancers that share similar biologies and features. And then we have RAS-driven poorly differentiated thyroid cancer and oncocytic thyroid cancer, which may have RAS mutations as well, but have very different biologies. And so understanding this genotype, phenotype, or phenotype, genotype helps us understand the biology of these different types of thyroid cancers. And this is a cartoon I've made to just help understand that, where hopefully this is not cut off for everybody else. Like it's a bit cut off for me with a slide bar up here, but I think the low-grade papillary thyroid cancers express the TSH receptor well, express NIS, and produce thyroglobulin. Whereas as they acquire, and these are primarily BRAF or BRAF-like mutations, as they acquire more advanced histologies, usually from mutations such as TERT or ARID or TP53 or others, they start losing thyroid gene expression. They produce less thyroglobulin, they have less or no NIS expression, so they do not take up iodine, and they may not express the TSH receptor, and this will be important later when we talk about TSH receptor CAR-Ts. And then the follicular thyroid cancers, the follicular patterned lesions, do have lots of TSH receptor expression, NIS, and thyroglobulin, whereas oncocytic thyroid cancers, while they produce a lot of thyroglobulin and may express TSH receptor, they lose NIS expression. And then the poorly differentiated thyroid cancers, which are really like these advanced papillaries, where they probably don't express NIS, don't produce much thyroglobulin, and may or may not have expression of TSH receptor. So understanding this, we apply this tumor phenotype genotype to approaches. And really, I think about thyroid cancer and our approaches as a risk-adapted approach. What is harmful or limited benefit for low-risk disease? what therapies can reduce recurrences for those with just lots of nodal recurrences or neck disease, and what are treatments that we can offer in advanced disease that improve survival or maybe even induce complete remission or cures of the disease, if we can be so bold. So approaches for patients with advanced disease, this is what the lens through which I see patients in oncology and what I think about. And it's really patients who present on the left here with microscopic, very low volume disease that's slowly growing. There's no symptoms, and this patient may be in surveillance for years and years, 10 plus years, before there's any significant, or if there's any significant progression. Whereas this patient is the most advanced and needs immediate treatment. And many patients fall in this category with macronodular disease that's either moderately or rapidly progressive. Many of these are slowly progressive, and it's a tougher decision. When do we start treatments? And if so, which treatments, etc. When we think about the treatments for thyroid cancer, we have many first and second line options with multi-kinase inhibitors that target the blood supply. This is lenvatinib or Lenvima, and its primary efficacy is likely through VEGF targeting, VEGF receptor targeting, and anti-angiogenesis. We have molecular targeted treatments with dabrafenib and trametinib for BRAF mutant disease as either first or second line. We have selpercatinib or pralsetinib if patients do have a RET mutation, and other targetable drugs for NTRK and ALK fusions. And then we have other cabozantinib, sorafenib treatments. These are all treatments we can generally get through FDA or NCCN approvals for. And then we have alternative options when either these don't work or when we're trying to avoid these treatments, perhaps radioiodine redifferentiation as an off-label approach, and other off-label treatments that are not approved but we think may have efficacy in the disease, and of course, clinical trials. And of course, we're thinking across the spectrum from the different phenotypes that I just outlined previously. So in patients with advanced disease, the lens through which I see patients, I'm thinking about thyroid hormone suppression, surveillance alone for low risk, indolent, or slow growing disease. Consider multi-kinase inhibitors for these patients versus oncogene targeted treatments. I think about redifferentiation or off-label in clinical trials. And so we're going to focus on the off-label therapies and clinical trials today. So I'm going to start with pemetrexed carboplatin, an old chemotherapy regimen that's used for lung cancers, and surprisingly has some really promising results in patients with advanced thyroid cancer. And this is work that I'll share that's shared by our endocrine oncology team at Mayo Rochester. When we think about cytotoxic chemotherapy, these are two brief cartoons to help us conceptualize how chemotherapy works. So we have here DNA. Cancer cells need DNA to grow and divide. They require precursors, purines and pyrimidines, to make the AGCT that makes up the backbone of DNA. And there are enzymes that are involved in incorporating these purines, pyrimidines into double helix DNA. Then this gets transcribed to RNA, messenger RNA, that then takes that code from the DNA and translates it into protein and function. And cancer chemotherapies can target any of these steps generically, sort of, to target the cancer and to impair DNA replication and function and to induce cancer remission and control. And so these are examples here of the different types of chemotherapies that can function and target the DNA, RNA, and proteins that can be used for patients with cancers. So pemetrexed is an example of one of these metabolites, anti-metabolite. Pemetrexed is a multi-targeted anti-folate metabolite that it inhibits 3 enzymes involved in the process of purine and pyrimidine synthesis. So it targets this pathway up here. And by doing this, some cancer cells are particularly susceptible to this and undergo cell death and tumor control. With this type of chemotherapy, there is the risk for, most common risks are bone marrow suppression and mucositis, sort of painful sores of the mouth. And these side effects are limited or decreased by giving back folic acid and B12 to help support the bone marrow. This chemotherapy, pemetrexed, was first used in a clinical trial in 2009, so actually many years ago. And in this clinical trial, they combined as a phase 1 study pemetrexed with a PKC inhibitor. This was a phase 1 study, so they accrued all patients with advanced solid tumors and looked at outcomes. And what the outcomes showed is there were 3 objective partial responses, and all of these responses occurred in patients with thyroid cancer. One patient had tumor reduction of 86%. There were 20 patients, or 30% of patients, 9 with thyroid cancer, had a best response of stable disease. And stable disease might not sound attractive, but for a phase 1 study, most of these patients had progressed on first and second line treatments and have advanced disease and little other options. So even stable disease is not a bad outcome. In total, there were 13 patients in this phase 1 study who received this chemo combination. The response rate was 23%. 9 of 13 patients had best response of stable disease. 4 patients received at least 10 cycles of therapy, and 1 patient had the highest number of cycles, over 12, suggesting there was a durable or sustained response to chemotherapy. Interestingly, in parallel, over the last 10 years, you may be familiar with Dr. Keith Bible. He's a well-known oncologist and an endocrine oncologist who treated advanced disease for many, many years at Mayo. He's now retired, but he's a very astute and very thoughtful oncologist. And he had a patient who had both lung cancer and thyroid cancer. And when the lung cancer was treated with pemetrexed and carboplatin, he observed that there was improvement in the thyroid cancer unexpectedly. This was presented at a an abstract in 2016, and I'll just highlight this. This was a patient example who had lung nodules shown here and here, which after 6 cycles of the chemotherapy showed significant control and regression. This was a BRAF mutated papillary thyroid cancer. At the time, Dr. Bible had a lab and was doing work on with thyroid cancer cell lines. Excuse me. And he took 4 thyroid cancer cell lines and did colony forming assays or growth assays with these cells. 2 of these cells were not BRAF mutants and 2 were BRAF mutant. And he treated the cells with higher doses of pemetrexed. And what they saw in this small experiment was the BRAF cell line seemed to be inhibited and growth reduced compared to the BRAF non-mutant or the wild type cells. So he suggested or predicted that maybe BRAF is a marker of response to pemetrexed. So back at the clinic, this led to our many years of off-label pemetrexed carboplatin combination chemotherapy strategy for our patients with advanced disease as a salvage therapy in patients who had progressed on multiple other standard systemic treatment options. So this is an example of one of the best responses and one of the first patients I inherited from Dr. Bible when he retired. And I was stunned with the response. This was a 35-year-old male. Sorry, I have to I cannot move my toolbar and see my own screen, but this was a 35-year-old male with a BRAF mutant. Sorry, he was not BRAF mutant. He was with a papillary thyroid cancer that was very locally invasive. He had progressed after multiple surgeries and doses of radioactive iodine and had been treated with lenvatinib, pazopanib, everolimus, was no longer surgically resectable, no more radiation could be given, and as a last salvage option, Dr. Bible put this patient on pemetrexed carbo. And the patient proceeded to have an amazing response that was durable for many years. His genomics showed actually no BRAF mutation, but instead a dicer mutation. But nonetheless, he had a significant response. Unfortunately, the patient passed away from complications of aspiration pneumonia and sepsis, but he had a response and good control for at least 3 years for otherwise untreatable disease. The next patient is an 80-year-old patient with metastatic papillary thyroid cancer with a BRAF fusion. And her disease, as shown here, had pleural-based nodules, which were progressing and pretty significant. She had an effusion and really significant disease. She was treated with lenvatinib, followed by dabrafenib, followed by pazopanib, and as a final salvage option was offered pemetrexed carboplatin in October 2019. The dose had to be adjusted, and we dropped the carboplatin and then proceeded with pemetrexed alone since 2020, December. And these are the patient's baseline scans before pemetrexed, and this was after 3 years on pemetrexed. And hopefully what you see is that there's much more black and less white, less tumor here. This 80-year-old patient had a very good quality of life for many years, went on cruises, and really tolerated the treatment for the most part fairly well. Her disease eventually has been progressing and had to go back on other treatments, but for 3 years had a good quality of life. And this is another patient with BRAF mutant papillary thyroid cancer whose disease progressed to even included anaplastic thyroid cancer transformation. He initially responded very well to dabrafenib and trametinib. These are drugs which inhibit BRAF mutation. He then progressed with disease again shown here and sort of in the background and was put on lenvatinib. He had progression on lenvatinib and then was put on pemetrexed carboplatin every 3 weeks, and for a year had a durable and quite nice sustained response. After a year, the disease did progress, but for a year he had good control. And this was perhaps one of the most dramatic cases I saw of one of my patients who had really extensive oncocytic or Hürthle cell thyroid cancers, and on PET scan has just really diffuse bone metastases. And after multiple treatments with lenvatinib, immune therapy, cabozantinib, I suggested this regimen, though I had never done it in Hürthle cell or oncocytic thyroid cancers. They're not typically BRAF mutants. And he had an amazing response. And so we have just amassed our 11 patient case series and submitted our manuscript that has just been accepted to head and neck for this regimen. Oops, sorry. Out of 11 patients, these are all the responders and these are the non-responders. And we see that in the BRAF, there were at least 1, 2, 3, 4, 5 BRAF mutant cases, and 4 out of the 5 BRAF mutant cases were responders. But that there were others, such as this dicer1 mutation and this oncocytic thyroid cancer, that was also a responder. We had 4 non-responders, including 2 with anaplastic thyroid cancer and 2 poorly differentiated. When we look at the previous treatments these patients received, they were multiple with one exception. So this was 4th or 5th line option for many patients. This is just a waterfall plot showing the change in tumor size across these 11 patients, where we see some dramatic tumor regression, some stable disease, and then some with ongoing progression here. For those that had thyroglobulins that were evaluable, we tracked the thyroglobulins. This patient's thyroglobulin increased, whereas this patient's decreased substantially in these 3 cases, suggesting good response. So pemetrexed carboplatin has durable RECIST responses, both partial responses and stable disease, in advanced life-threatening metastatic PTC and ATCs and oncocytic thyroid cancers, perhaps. BRAF may be particularly responsive to this salvage therapy, and there may be some genomics that can predict side effects and or responses to therapy. And certainly we do need a phase 2 clinical trial to really understand in a broader context of patients' efficacy, identify response rates, and biomarkers of response. I'm hoping that this strong data alone will be sufficient for patients to get this treatment approved as an off-label option if it's appropriate, and may one day at least be within NCCN guidelines as a consideration. So let's switch courses and talk about a new therapy, an immune therapy. And I know there have been several immune therapy sessions at this meeting, and this may have been covered in one of those other sessions. So TSH receptor is an important target in thyroid cancer. I don't know why that's doing that. TSH, this is a cartoon of a thyroid cell, a normal thyroid cell, which has resemblance to thyroid cancer cells. The thyroid cell has this protein, TSH receptor. It responds to the hormone TSH hormone, and in response to TSH hormone binding this receptor, it triggers iodine uptake, which is needed to make thyroid hormone. Thyroglobulin, it stimulates thyroglobulin production, and T4 and T3 secretion. So TSH signaling and TSH receptor is really an important protein in normal thyroid cells. And we know that this receptor is selectively expressed primarily in thyroid cells, although there may be some expression in orbital fat cells as well. And in thyroid cancers, we think that at least some thyroid cancers, these and these, express the receptor. Advanced ones may have limited or retained expression of this receptor, or may have inducible expression of this receptor with targeted treatments. And we'll talk about that. So what is a CAR T? A CAR T is a type of an immune therapy that takes one's own T cells, these are the cells that fight cancer, and trains them or educates them in the lab to recognize and kill cancers. The T cells are not killing the cancer because they don't recognize the cancer as foreign, or they haven't seen the cancer as a cancer. So if we educate the T cells, give them a protein to hone in on and express, then every cancer cell they see that expresses that protein will undergo, hopefully, cell death. So a TSH receptor CAR T is an immune therapy that takes your T cells and engineers them to express the TSH receptor, and that becomes the target that they then seek out and kill all cells that express that receptor. So it's a form of targeted immune therapy for thyroid cancers. And this is a nice schematic from NCI and clinicalcancer.gov showing that T cells are taken out from a patient, they're taken to the lab, and they're engineered to insert a gene. This gene will express a specific T cell type of a receptor or an antigen. These cells are then grown and expanded, and then they're given back to the patient. This is the CAR T. And the hope is that the CAR T, with these new receptors, will recognize the cancer as antigen and then kill that cancer cell. So we have, with this work has been led by Al Copeland, a PhD in Mayo Jacksonville, in collaboration with Dr. Saad Kandarian, a hematologist who's an expert in CAR T development, and myself for the clinical aspect of this as it moves to the clinics. And so the best candidates for this type of CAR T trial certainly will be those that express the TSH receptor well, and these are the follicular patterned lesions shown here, and perhaps these ones, the RAS-driven tumors, which are these, and tumors perhaps classical PTCs that have the high thyroglobulin. Thyroglobulin may be a biomarker of how well the cells express TSH receptor, and that remains to be determined. It is possible that for disease here, and maybe even here and here, that doesn't express the receptor well, that we might be able to use drugs such as BRAF-driven inhibitors in BRAF mutant disease to re-express the receptor, and so that we can then treat with the CAR T. So this is cartooned here, that when BRAF, RAS, or RET are turned on, and it signals through this cascade downstream, not only do you have cancer growth and spread, but this leads to loss of thyroid gene expression. particularly of the iodine channel, of TSH receptor, and thyroglobulin. However, we can target this with drugs that inhibit the BRAF mutation or downstream of these mutations with a MEK inhibitor, and this might both control the cancer, but importantly, might restore thyroid gene expression, particularly of the TSH receptor. So that CAR-Ts might be then broadly used for patients with follicular RAS-driven tumors at baseline, and then in combination with targeted treatments that induce TSH receptor in the more advanced cases, poorly differentiated, even perhaps pie in the sky anaplastic thyroid cancer. But that really remains to be seen. So this is a schematic that we're looking at. These are the histologies, these classical or RAS-driven thyroid cancers that still express TSH receptor well, might be good candidates for this study if they have advanced disease, whereas these that are primarily BRAF-driven, that have lost TSH receptor expression, we might be able to induce this expression, take these from here to here with targeted treatments. So that's an exciting development. And while as the clinician and the clinician scientist, this treatment I was hoping would be available already this year starting, but we're at least a year out. The important thing is many others, not just Mayo, are looking at similar treatments using bispecific or trispecific antibodies, not necessarily CAR-Ts, or even other forms of targeting this pathway. So I think we're in an exciting time where curative treatments for at least some patients are on the horizon. So I want to switch gears to a different type of treatment now. This is trastuzumab deruxtecan. This is a clinical trial that's long been in development by Dr. Eric Sherman from MSKCC, and I'm thankful for Eric for sharing these slides with me. This is a novel treatment for thyroid cancer because it uses a HER2 antibody that is linked here with a linker to a payload here, DX, which is a cytotoxic sort of chemotherapy that targets topoisomerase. So it's a cytotoxic chemotherapy. So it's an antibody drug conjugate where the antibody homes to tumor cells that express the HER2 antibody, and it delivers a payload here, a cytotoxic chemotherapy, to help kill that cell. So this is cartooned here, that this antibody drug conjugate, TDX, binds to the HER2 cell. This HER2 binding undergoes endocytosis, which means this complex is taken up into the cell, it's broken down, and as it's broken down, it releases the payload. Here's the chemotherapy that then diffuses into the nuclear membrane, where it causes DNA damage and cell death. And this chemotherapy can sometimes diffuse through the cell membrane and back to surrounding cells and have a bystander cell effect as well. So what is the rationale for using this in thyroid cancer? So BRAF-driven thyroid cancers have a resistance to BRAF inhibitors. And this has been shown by Jim Fagan's lab and work from his lab many years ago, that when you treat with BRAF inhibitors in BRAF mutant disease, you induce expression of the HER2 receptor. This is not normally expressed except when we treat with DT in BRAF mutant tumors. So, and HER2 expression allows the cancer cell to sometimes bypass these drugs to reactivate cell growth and proliferation. So by targeting HER2, we can enable a novel delivery of focal chemotherapy to these cells to have better tumor control. And so this is a novel form of targeted chemo combination therapy. The schema for this is BRAF mutant disease, BRAF mutant thyroid cancers who have not been treated with BRAF inhibitors, does not include anaplastic thyroid cancer, and as most clinical trials must have resist measurable disease and some resist progression prior to study entry. Patients will be stratified based on prior VEGF treatment, such as lenvatinib. Patients will be radioiodine refractory. They'll be stratified by their different prior exposures to treatments and then randomized to either dabrafenib, trametinib alone or dabrafenib, trametinib plus TDX. And then at progression, if these patients progress on DT alone, there is crossover for DPT. So the primary objective is progression-free survival. Secondary objectives are response rates. There'll be about 84 eligible patients based on power studies here. And I expect this to be a multi-center study that may be done through ITOG, if I'm remembering correctly. And then finally, one last study to highlight that I think will be open in the future soon, also through ITOG, is a new compound from Exelixis, XL092. This is a multi-kinase inhibitor, and the scope of this new drug is as a multi-kinase inhibitor, probably similar to a cabozantinib type drug, but perhaps more potent, is a neoadjuvant treatment. Neoadjuvant means patients who present with locally advanced differentiated thyroid cancers that may be hard or complex to remove or resect. Patients are then eligible for this study, and the hope is that treatment with this drug for 1 month or 2 months may enable easier resection and better resection of all gross disease. And so this is the brief study schema. Patients who enroll in this study from multiple centers will be put on monotherapy. Tumors will be reassessed after 2 cycles. Patients may receive up to 2 to 4 cycles of oral therapy and then either move on to surgery and follow-up. If tumors have progressed or if there's been no response, they would come off study and proceed with either surgery or next steps in their care. And this is going to be led by Mark Zaffario, a surgeon from MD Anderson Cancer Center. So this will be a multi-center phase 2 open label single arm study looking at this XL092 compound. And I think that's it. That's all I have. Highlighted for today. And I wanted to leave plenty of time for questions because I know there's many questions, and happy to take and answer what I can.
Thank you so much, Dr. Ryder. I'm so excited. I'm jumping up. This is really amazing. You're right. This is an amazing time.
Certainly okay. I think it's newer concepts, certainly very different than traditional multi-kinase inhibitors, radioactive iodine. So certainly understand this is different kind of treatments to wrap one's mind about, but I think also exciting.
Yes, I remember hearing about carboplatin for other types of cancer. So that's exciting to see that there's another opportunity and a way to look. Okay,
Yeah.
we've got one question. The new medications, do they also target the additional tumors our bodies may be creating?
I guess it, the hope is that, at least for the immune therapies, they would hopefully target all the existing cells that we can see radiographically. I would hope that it targets the microscopic disease that eventually leads to the new disease as well. So, and I think that's the benefit of CAR T immune therapies, that the T cells will have a memory and be able to ongoing fight new disease as it comes up. I think that's the potency of immune therapy, is the memory that T cells may gain to be able to continually screen and eliminate cancer cells as they pop up. But that's also what the clinical trial, data will be. And I think it's an exciting time, but it's also an important time of cautious optimism. It takes a long time for these therapies to come forward. There's a lot of optimism, but there's also a lot of work to do to make sure it's safe and it's effective. I didn't talk about the toxicities, but CAR T treatments can be highly toxic. And even that is improving as CAR Ts have been at least used routinely in hematologic malignancies.
Okay, so I think that kind of covered the next question about side effects. But are any of them like a short term? that can be stopped and rather than an ongoing treatment?
So I think the CAR T, the way it's done is it is a one-time infusion, but it requires some chemotherapy. Then you get the infusion, and then there's observation. And then the hope is that the CAR Ts will have memory and that they will have ongoing efficacy. And so I think with the bispecific antibodies that they're also developing, it will be interesting to see what that durable responses also look like.
So with the CAR Ts, are you seeing side effects that are more immediate
Yes, I mean
after that, or are they
there are.
continuing long ongoing?
I'm sorry.
That's
So
okay.
CAR Ts right now, patients are often hospitalized for at least a week and they undergo observation because there can be very serious CNS toxicity. When you turn on the T cells and they start fighting the cancer, they release a lot of cytokines. And so there's a cytokine release syndrome that's well characterized and can be even life-threatening. So it's very serious. It's not an easy treatment. When you turn on the immune system, it's a good and a bad thing sometimes. And so you have to be able to harness that and control that. And it can be difficult. Um, so I think it's going to evolve and see. It sounds, I've been in this field a long time. Whether you can really do one treatment and you cure a patient and you're done forever is certainly optimistic, but I would say if you have to retreat a patient later, if cancer cells reemerge, can you retreat with a CAR T, same CAR T, and it still damage those cells, and it's still a sort of a one-time, one session at least. So I think it's a lot of questions that it's exciting that the field is moving to endocrine cancers, and we'll be able to answer some of these and know these in time.
Excellent. Good to know.
Mm.
If a patient's interested in seeing you for a consult, what's the process to
Um,
achieve this? Do we need to be referred?
Yeah, so you can go on mayoclinic.org and there's an appointment office or appointment line, and you can certainly get a referral from your provider, but also make an appointment. Yeah.
Excellent. I have a caregiver that's asking about their wife has oncocytic with DAX genetic mutation. Could these therapies help with her condition?
Yeah, it's a very good question. I'm not sure that which therapies you're thinking about, but again, I don't have enough information. I have only one patient that, for example, was treated with pemetrexed carbo, and this was after the patient progressed on multiple other first-line treatments, such as lenvatinib. So if it is an oncocytic cancer patient who has progressed on several other first-line treatments, lenvatinib, cabozantinib, pemetrexed is the one that could be available. The CAR T is not available for another year or more, but the DAX genetic mutation wouldn't necessarily make them eligible or ineligible. It's the TSH receptor expression, whether her cancer expresses that or not, would not be eligible for the HER2 antibody conjugate because of not having a BRAF mutation.
Okay. Is it expected and usual for the BRAF mutated patients to not express THSR well?
TSHR. Yeah, so I think BRAF-driven papillary thyroid cancers are a spectrum. And on one end of the spectrum is the probably very well differentiated classical low risk PTCs that probably do express TSH receptor, thyroglobulin, and that's why when you do thyrogen or hypothyroid stimulation, you see a bump in their thyroglobulin. Those likely, especially if they have TSH thyroglobulin goes up after thyrogen stimulation, really confirms that they likely have some expression. The question for our trial is going to be how much expression of the receptor is needed to get a benefit from the CAR T cells. In other words, do you have to have high level expression, which usually is the case, or can even medium or low level, but still there, be sufficient? And on the spectrum of BRAF mutant disease, there is the other spectrum of more advanced disease where the thyroglobulin doesn't stimulate. or the thyroglobulin is near zero, despite lots of disease, that patient unlikely expresses the receptor on their own. But with BRAF inhibitors, dabrafenib and trametinib, we might be able to re-express it at a much higher level and then pair that with a CAR T or a bispecific antibody that's been developed somewhere else.
If BRAF with RAI resistant, is CART better to consider before radiation therapy and multiple surgeries?
Really good question, Rose. I would say right now this is entirely too early to tell. This is going to be a phase 1 study, which means that it's only going to be approved after traditional radioactive iodine, other systemic treatments like lenvatinib, dabrafenib, trametinib, etc. But if we fast forward 5 years from now, and if we get our wishes of pie in the sky, where the CAR T works very well and it's very safe and well tolerated, then you could envision where these types of treatments become the first line, and that all of our other treatments become salvage treatments and others, saved for if the CAR Ts don't work. So that's the dream. But it's going to take, at least another 5 to 10 years to get to that step.
Okay. For the clinical trial, are they actually open now for that
No,
or not yet?
we're
Okay.
not open for potentially another year, although
Okay.
that's too soon. I was hoping this year, but I'm always overly optimistic, but realistically, we're hoping third quarter next year, but most likely, realistically, 2026, I suspect. But again, others are developing similar types of approaches, which is exciting. So there may be others who are ahead of us and may be able to open sooner.
Okay. And then if a patient presents with progression after 5 years, controlled with dabrafenib and monotherapy, what would you look at as a second line therapy?
So, interesting question. I think it depends on the extent of disease and the type of progression, whether slow or rapid, extensive disease versus not extensive. There could be an option for adding trametinib. I've done that in one patient who had been on monotherapy for many years, slowly progressed, and then I added trametinib, and there's some rationale for that. Alternatively, I consider lenvatinib would be, if a patient has not been on lenvatinib, that's probably considered first line, often, even before dabrafenib in some patients. But if that's already been done, you're talking about third line, and that could be cabozantinib, which is approved in this context. There is going to be a trial comparing second line cabozantinib to dabrafenib and trametinib to understand what second line should be. But so this would be after you progressed on lenvatinib, though. Pemetrexed carboplatin, if you're getting into third and fourth line options, that's when I consider pemetrexed carboplatin or even other clinical trials that might be available.
Thank you for that. How far out are the pemetrexed bees, and soon can we see these?
So pemetrexed is currently, unfortunately, we approached Lilly many times to do a clinical trial in the hopes that we could get this treatment approved for thyroid cancer. And unfortunately, we were declined each time. And so there isn't a clinical trial active right now, although I am in collaboration and discussions with my ITOG colleagues to try and do a multi-center shoestring budget type of trial. Pemetrexed did become generic. So it is now a generic chemotherapy, so cost is much better. And with the publication of the phase 1 study and with our publication of our case series, my hope is that it may be an off-label treatment that patients can apply for with their providers, oncologists, and get it approved. So many of our patients, that case series of 11 patients, were treated off-label and what it was covered. So in other words, you can get this covered through your insurance until we have a phase 2 kind of identifying the best way to get this. I think as part of our case series, and because this is an important salvage option for life-threatening disease, really, that NCCN likely may review this and hopefully put it in their guidelines. And if they do, that can make it also accessible to patients, even if it's not FDA approved. And I'm not sure, because of no sponsors are willing to do this study, the funds to do a trial like this are very difficult. And so there may not be ever a standard phase 2 or phase 3 trial done. But if it gets in within NCCN, there's still at least payer support for it. So I hope that makes sense.
It does. I just wondered, like, what can we do as patients? We call Lily and go, hey.
Well, now it's generic, so I think Lily will have continued lack of interest, unfortunately, for this. But we as providers are, again, there's things that we can do on a shoestring budget and multi-center and accumulate patients and still try and expand our use. But I think what the data we have already, unfortunately, 1 or 2 patients come along where the insurance denies it, and so we can't use it. But we're successful in most cases. So
Do we know if being RET positive has any impact on the efficacy of future CAR therapy?
we won't know that.
Okay. And could you explain the CART slide again more easily? How do you train the T cell to target the THS receptor?
Yeah, so that's done genetically. So the T cells are taken to the lab, they're put in a dish, and it undergoes gene therapy to get the T cell to express that TSH receptor. So they use a lentivirus or other modalities. It's a form of a gene transfer, gene therapy to get the cells to express it. I wish I had a better picture to show that, but but that's essentially what it is. They've identified the specific TSH receptor that T cells can recognize, and they genetically modify those T cells in the culture dish in the lab to express that specific construct. So it's gene therapy.
We do have another question from an online group. Will you accept patients from outside the United States for the CAR T TSH receptor trial?
I think that's too early to be able for me to answer right now. Logistics of this might be difficult. I don't know that we've addressed this specifically. At Mayo, we see a lot of international patients, and there's not necessarily a exclusion of international patients, but the CAR T's trials, when they open, are very slow accruals because they're a phase 1. And so we can only accrue 1 patient a month at a time. And so it takes many years, probably 2 to 3 years, before we really get up to enrollment of many patients. So it's a very slow process, and that makes it logistically difficult for international patients.
Absolutely. Oh, and one more question. Again, thank you for your time. With Hürthle cell, is there any mutations to look for on the things that you talked about today?
Yeah, unfortunately, Hürthle cells don't express BRAF mutation, but as I showed with pemetrexed, we had the one responder who was not BRAF mutant, who was a Hürthle cell. It could still be a responder to CAR Ts, independent of mutation. Hürthle cells may still express TSH receptor well. We're hopeful about this. At least preliminary studies seem to suggest that Hürthle cells will express the receptor. So independent of their genomics, that may be helpful. Hürthle cells would not be eligible for the study with the HER2 antibody conjugate, because that's only for BRAF mutant disease. But thank you, Anjali, and thank you, everyone, and thanks for your again, to all the patients and your thoughtful questions that, help drive us, what we're doing in the lab, what we're doing in the clinic. And I have to say, of all the papers I've published, the pemetrexed paper is my most fondest, because it's bringing a treatment that's been around to more patients, and readily available and tomorrow, as opposed to we're always impatient, and I'm impatient about the CAR T taking so long. So I think, again, I'm grateful to all my colleagues as well, and for the work that they're doing, not just at Mayo, but throughout this thyroid cancer community is a really thoughtful community and really hardworking people. So lots of progress being made. So
That's
thank you. I
exciting.
appreciate everything.
Absolutely.